Or, oh no, they didn't find anything.
Where was it?
I don't think this is it.
Yeah.
That's fine.
Oh, we got notes?
No, that's because it's my computer.
I love it.
That's,
I want notes. I can do that? Oh, terrific.
Okay.
Oh, good. Notes. I don't have to use this.
Everything else is
I
there.
love that. Yeah.
Make sure you're recording.
Okay, yeah, make sure.
Yes, you're recording. Here you go. That's why I keep telling Dr. Mostello to go to 2015.
I never from her projector or laptop. Awesome.
Right. Bless you. Oh, maybe someone's going to sit there. Is Dr. Mara coming back, or?
No, he's in the yard.
Oh, you're kidding. Do you know they're filming a commercial during this session and including one of our fellows? This is totally inappropriate. I told him I couldn't go because I was giving the lecture.
It's inappropriate on many levels.
On many levels, but
That's only one of them.
Well, we're here.
I know you're here. I just think it's... I don't see Gary. I don't know where Gary is. But I'll just start talking. Okay. So the topic for today was uterine physiology, but when I looked through the learning objectives, Dr. Ramon had covered 90% of them in his lecture just a few months ago. So rather than rehashing what he had done, I decided to focus on one of the objectives, which is cervical ripening. And that's a topic which is near and dear to my heart, and that I have been following for more years than I would like to take into account. It's interesting because I started using prostaglandins for cervical ripening as a resident. We just did it, and it was back in the days when it was just coming around, and you would make a sort of, the pharmacy would make a slurry of this stuff with a Prostin 20 milligram suppository and some cellulose gel, and draw it up into a syringe, and you'd administer it in a variety of ways. In the vagina, in the cervix, into a diaphragm, very many different ways. But it worked, and it was great. And the trick thing is, when I moved to my fellowship, Cincinnati was not using prostaglandins, and so I got to bring prostaglandins to Cincinnati. And at the risk of sounding like I'm Al Gore, I also brought prostaglandins to St. Louis because they weren't using them for the longest time at WashU. They never used the stuff. So I had a protocol and developed it. And shortly afterwards, a proprietary preparation came out at that point. But it wasn't something that was commonly used at all. So there's a lot of literature, and I think what we have available to us today, we just sort of take for granted. But if you don't understand what it's really doing, you can't really use all the products to your advantage. And so that's what I'm trying to focus on today. So in preparing the cervix for labor, I'm going to go over sort of these topics. What's the physiology, the different agents, the comparative studies, and cervical ripeners in terms of do they really do anything, and how much they cost, that kind of stuff, and a little bit of what's on the horizon. So if you have a favorable cervix, labor goes much better. The cervix goes from a long and closed and firm organ to something that's soft, pliable, and yielding for contractions. Without that, labor doesn't progress very well. The cervix is made up of smooth muscle, elastin fibers that are mainly around the internal os, lots and lots of collagen. And the collagen fibers are arranged in bundles. They're parallel, and they're bonded to proteoglycans, which form bridges between them. And it's that collagen and those bridges that are the key to what makes the cervix change from firm to soft and pliable. So when we look at cervical ripening, we look at sort of that process, and it's still not well understood why it happens. We know that it does. We know a little bit more about the biochemistry, but we know nothing or very little about the why and the trigger in humans. So the changes in the cervix include the breakdown of the collagen by enzymes. Have a seat. The production of hyaluronic acid by fibroblasts, which pulls in water, and the fibroblasts make IL-1 beta. There's decreased concentration of dermatan sulfate, which disrupts the bridges between the collagen fibers, infiltration of PNMs, and a local increase in prostaglandin. And it degrades, the collagen is degraded to the critical length for tensile strength. The IL-1 beta stimulates arachidonic acid metabolism and fetal fibronectin release. There's platelet activating factor and nitric oxide. Phospholipase A2 activity is increased by IL-1 beta. And the metabolic activity of the cervix is under hormonal control, and it's very complex, and it's still not well understood. Of note, lipopolysaccharides, which come from infection, also can induce these changes. So it may be why people with choreo start to have cervical changes. This is a complex figure, but it's just, I think, helps you see the kinds of things. It's a rat cervix. That's why there's day 6 and day 17. I think a rat gestation is something like 21 days. Once upon a time, I used to know that. You'll see the long collagen fibrils in B linked by those proteoglycans. And then they become disrupted, and those collagen fibers, the long blue strands, become shorter. So it's just a graphic representation of what happens. And it's studied in humans as well. It's just not as precise. So again, why these things happen, we still don't know. I mean, I wrote this slide 15 years ago, and it is still true, unfortunately. So how do we measure preparedness of the cervix for labor? So the Bishop score is probably still the best way. I'll have that in the next slide, but even though it's subjective, it's somewhat quantitative, and when compared to other so-called more objective measures, it still wins because it doesn't cost much, and the other methods aren't any better at predicting preparedness. So fetal fibronectin, although it's claim to fame for having excellent negative predictive value for preterm labor, is also been a good predictor of response to induction. So if someone has a high fetal fibronectin level, almost anything you do to induce them will work. So and some people think that perhaps ought to be just like a positive or a negative fibronectin or a positive fibronectin ought to be how you choose the people to test your tocolytics on. Maybe a negative fibronectin ought to be how you choose your cervical ripening agents on. We know that when there's positive fibronectin, there's a shorter time to delivery, shorter first stage. In studies, it's independent of the Bishop score, but it doesn't change much. It's not any better than the Bishop score. At cervical length by ultrasound, again, correlates with the length of the latent phase. No surprise there. But again, no better than the Bishop score. There's something called a coloscope, which probably about, 7-8 years ago, people thought, oh, this is going to be great. And you put it on the cervix and you get this light-induced fluorescence, and it is an index of cross-linked collagen, but it's no better than the Bishop score. So, I guess it takes a lot of training for your 2 fingers to figure out what the Bishop score is, but you're still more cost-effective and equally as predictive as a more expensive test. So the Bishop score, there are many modifications, but this is the Bishop score. It takes into account 5 qualities of the cervix. And the ones that we're used to talking about that get posted on the board are dilation, effacement, and station. And there's modifications where you use centimeter length instead of percent effacement, but it boils down to the same thing. But consistency and position of the cervix are also critical in determining the Bishop score. And some of the things I'll talk about rely on this Bishop score in assessing the efficacy of some of the ripening agents. So I put that there for your consideration, so you know. I know a lot of you use this on a daily basis, but just to know what it is. It's interesting, Bishop, when he developed this score, he said when all there was for induction of labor was amniotomy, said that if you had a score of 9 out of a maximum possible of 13, that it was reasonable to induce labor if you were multiparous. So that was his conclusion with the initial presentation of the Bishop score. So 9 is considered very favorable, and we don't even think twice when someone has a Bishop score of 9. They just get to go into labor. They all respond, and so he was right in that regard. So when we talk about cervical ripening, what would be the ideal agent? There's a lot of sort of hopeful description of this, and this product does not exist. Something that's physiologic, it doesn't necessarily cause contractions or hyperstim. It can be used unmonitored, doesn't affect blood flow, doesn't affect the maternal fetal unit, no side effects, doesn't jeopardize future pregnancies, and cheap, and none of that exists. So although many studies talk about a difference between ripening and induction of labor, I think it's important to remember that it is a spectrum. And many agents, there is overlap between cervical ripening and induction of labor. And the end point is a vaginal delivery with everybody doing fine. And so it really may not matter in most situations whether it ripens or induces labor or does both. But there may be some situations where one agent may be better than another. And this is sort of the list of all the things that could possibly be used for cervical ripening. And the good news is that they all work. So I won't be talking about every last one of these things, but they do all work. They've all been studied in various forms. And I guess I didn't put sex on there. That's also been studied. Sexual intercourse is on the list. It all seems to work. So stripping the membranes involves digital separation of the chorionic membrane from the lower uterine segment, done by inserting the finger as far as possible through the cervix and rotating twice through 360 degrees. It initiates the Ferguson reflex, producing a uterine contraction. There's an acute release of prostaglandins, and that peaks and then returns to normal. It hurts like hell, and depending on the desire to get into labor, some people are willing to go through that discomfort for the perhaps getting into labor at some point. When they studied it, they actually asked people if they were uncomfortable, and this was the conclusion that perhaps the subjects were just being polite because they didn't really do it on any kind of score. But anybody who's done stripping the membranes knows that it hurts. Foley catheter, how does this work? Well, there's several ways it can be done. The way that we are used to using here is to place the Foley catheter through the internal os and blow up the balloon above the internal os. You use a large balloon, and it can fill it usually close to 50 cc's. And you can, some people put traction on it, which is what we commonly do here, taping it to a leg. It can be applied, a weight can be applied to it. There are studies of infusing saline, which continues to disrupt the membrane junction and release more prostaglandins. Alternatively, it can be the smaller balloon can actually be placed at the internal os and blown up there, and that hurts like hell too. And it's been around for the longest time, and there's both, when it's been studied, it's both a mechanical dilator and it produces some of the local biochemical changes. There's something called an ATAD ripening device, and it works the same way as a Foley catheter. It hasn't really come into favor, but it avoids the need for traction in that it's a double balloon. And I don't have a picture of this, I'm sorry. The picture I had was too crappy to copy. And it's one balloon goes above the cervix and the other balloon goes below the cervix, so it sort of applies its own traction. And the balloons are filled to 100 cc, so it creates a larger disruption of the membrane interface. Again, this is another one of those things where it didn't cause discomfort, which I find hard to believe. They all stretch the lower uterine segments, strip the membranes. There don't seem to be any systemic side effects, but there is a risk of vaginal bleeding if there's a low-lying placenta and you're blowing up a 100 cc balloon. That could cause a problem. There is a risk of ruptured membranes with introduction of the catheter. Some people report it more so if a stylet was used or an intrauterine catheter. Am I not recording? Intrauterine catheter to increase the stiffness of it, and there is a higher risk of prolapse cord, especially with the larger balloons. Also in the mechanical category are the dilators that basically absorb water. The one we are probably most familiar with is laminaria, and they are placed in the cervical canal through the level of the internal os. They absorb fluid. You asked this question the other day, Katie, about how long do you wait? And from what's written, there's about a 25% increase in the size of them in 4 to 5 hours, a 90% increase overnight, so I would say 12 hours. So the longer you leave them in, typically the larger they get, up to a point. The synthetic ones don't take as long, but we don't have those here. And I think Dilapan is off the market now. It came back in some other form. And usually you put in as many as will fit in the cervix. And the laminaria come in a variety of sizes, ranging in, I think, from 2 to 9 millimeter wide rounds of seaweed in terms of what they look like. They look like little homemade cigarettes, I think. So it seems that they cause more than just mechanical stretching, and there are documented biochemical changes when they are introduced into a cervix. So increase in IL-1 beta, IL-8, elastase, prostaglandin E2, and F2 alpha. Low-dose oxytocin changes the Bishop score if it results in contractions, and otherwise it doesn't do anything. There's no shortening of an induction to delivery interval. There's some question as to whether or not it stimulates prostaglandin synthesis, and when studied, it is better than expectant management. Breast stimulation has been studied mostly in African countries, and it does result in a change in Bishop score and in active labor. After 72 hours, more people will be in labor than if there isn't breast stimulation, and it can be done either manually or with a breast pump. It is cheap, but the claims that it requires no additional monitoring in labor are only supported by when they looked in small studies at similar APGARs between groups. But in the Cochrane review, there actually was a comparison of multiple studies, and even though it didn't reach statistical significance, there was an increase in perinatal deaths when this was used. They, when it was done, they didn't tell people why it was done or how it was done. They just told them to do it, so it's not. They weren't very rigorous studies when it was done. And if you've ever used breast stimulation for a contraction stress test, you know that it can, that results in the release of oxytocin, and it can produce significant numbers of contractions, which is the point, but it also can produce tetanic contractions, and without any monitoring, you'd have to wonder that it could cause distress in some cases. So certainly, maybe in very, very low-risk populations, it may be an acceptable method, but the things in quotes are the concern. Multiple hormonal methods have been looked at. Estradiol works as well as prostaglandins in terms of release, in terms of ripening of the cervix, but not producing contractions. DHEAS, relaxin doesn't seem to work in humans. It's prostaglandins, that's probably where the money is. Both E and F have been studied. E works better, and those are the ones that have been marketed, are the prostaglandin E's. The change in the Bishop score produced by them is greater if contractions occur, but change occurs in the absence of contractions. So either documented no contractions recording or actively tocalized patients who are given prostaglandins will still have a change, and it's because of the biochemical changes that happen. And the key to what it does and evidence of its biochemical change is if you compare women who have undergone cervical ripening with a prostaglandin versus those who have not, the the economy is achieved in their shortened latent phase. It doesn't do much for the active phase of labor, but the latent phase is shorter, and therefore there's a shortened induction to delivery interval. There's decreased oxytocin use when you add up all the units used over the hours. There's decreased pain because of less request for an epidural. So there's a variety of ways it's been evidenced that it does make a difference on the way labor progresses. So prostaglandin E2 increases collagenase activity, elastase activity, hyaluronic acid, increased synthesis of dermatan sulfate, and it has direct action on smooth muscle. And it's differentiated between the contractile portion of the uterus and the fibers in the lower uterine segment. So the contractile portion responds by shortening fibers, i.e. contracting, and lengthening the fibers in the lower uterine segment. When they've done cervical biopsies in the first trimester, and this was done, I think, on women prior to termination, where cervical ripening agents can be used. The collagenase activity achieves its maximum after about 2 hours in the multiparous woman, about 4 hours in the primimparous woman. Elastase goes up about 7 times. The glycosaminoglycans increase. Hyaluronic acid increases about 50%, and it induces IL-1 production. And then there's an influx of water and breakdown of the collagen. So the biochemical changes that we talked about are induced by the prostaglandins. Misoprostol is a methyl analog of prostaglandin E1, and again is associated with an increased occurrence of vaginal delivery within 24 hours, a lower section rate, increased incidence of tachysystole. And the person who was marketing misoprostol, and I'm blanking on that, I think it was Schering, I'm trying to remember who marketed it originally, had no, actually, that it's an interesting history lesson when you read it in some of the books. They actually came out with a letter, probably about, I don't know, maybe 15 years ago, and sent it to everyone and said, this is not to be used in pregnant women under no circumstances. We're washing our hands of it, et cetera, et cetera. And so actually the ACOG and FDA got involved and, had to remind them that physicians could use drugs in any way they saw fit with, documented literature basis for use. And the ACOG said, well, no one consulted us, and there's a good body of literature that says this actually is effective in the pregnant woman for a variety of indications. And the manufacturer actually toned down. And then now a new manufacturer is actually using the compound to create a vaginal insert that may be marketed soon. But it's actually it was actually an interesting time. It was a anyway. The dose response curves for oral and vaginal routes still have not been well established. It's still a little bit of a crapshoot. We know a little bit about how we use misoprostol. It doesn't seem to be related to the vaginal pH, because basically misoprostol is made as an oral tablet. It's made to dissolve in the stomach. It's not made to dissolve in the vagina or be absorbed in the vagina. So what makes it work and what makes it dissolve and be absorbed isn't clear. We've have studies on various doses and their effectiveness, and I will talk about that. But there's not really a good idea of how it's absorbed and what qualities are important. We know that if you use enough misoprostol, you can produce a tetanic contraction and produce fetal death. There are multiple reports of uterine rupture, especially when it's been used in women with a prior C-section, and ACOG has a statement on that in terms of it's not to be used in cases with prior C-section. We have a little bit of idea about the pharmacokinetics. When given orally, I have a graph, it peaks in about 30 minutes with a rapid decline due to a pretty short half-life after that. Vaginally, the peak is more delayed and may not occur for 1 or 2 hours, and there's a prolonged time of exposure because it does break down slowly in the vaginal space. And when wondering about, how long do I need to monitor after I give this, when they looked at various studies, how long does it take to get to tachysystole, where there's too frequent contractions, it may be up to 4 or 5 hours. So it's not something you can put in, monitor for a little while, and then not worry about it. So that's the difference in the timelines between vaginal and oral, with the oral showing the rapid peak in the solid line and the dotted line with vaginal. So certainly prolonged duration of exposure when vaginal misoprostol is given.
These are all systemic levels.
Yes, plasma concentrations. So of interest, misoprostol is still a lot of people's go-to because it's the cheaper agent. And understanding, how you're choosing doses. I have 2 slides that look at doses and frequency of administration and the duration of labor and the incidence of tachysystole. So, it is true. The more you give and the more frequent you give it, the shorter labor will be. And people have studied this. So, certainly, and you can half the time by giving 100 milligrams every 3 hours. 50 every 4, you'll have a little longer time, but certainly maybe less tachysystole, but I don't know if that's necessarily true. If you start going down to the 25 microgram dose, there's less tachysystole, and it depends on how frequently it's given. And I think the latest recommendation is 25 Q4, and some people talk about maybe using 50 as your initial dose and then cutting back down to 25 every 4. But again, with only very empiric studies to support its use. So when we compare effectiveness of these varying agents, what are the things that you have to pay attention to in the literature? One of them is gestational age. Almost all the studies are done on term patients, and that's because it works better if you're term. But even between 37 and 41 weeks, it works better if you're closer to your due date than it does if you're at 37 weeks. So when they've looked at it and broken it down in terms of gestational age at administration, everything works better if it's a later gestational age. It works better if you've had a baby before. It works better if you've have a better Bishop score. And when you're comparing times to delivery, it's important to always pay attention in the literature for what they're including. Sometimes they include the time that the Foley catheter was in. Sometimes they don't include that. Sometimes they're just, they call labor what happens after they remove it. Sometimes they include that in the time spent. The dose and the timing of the dose obviously is important. The location of the application, the medium it's in terms of how fast it's absorbed, released, liquefied, and whether it's a proprietary versus a compounded formulation. And it speaks to the degradation and stability and the homogeneity of the product. And we are used to, I think, very much, we use misoprostol and we use proprietary formulations, primarily Cervidil, for what we do. But there's all sorts of other stuff around in the world, including 1 and 2 milligram prostaglandin E vaginal tablets that are around in the rest of the world. There are Prepadil is still around, even though we don't use it here much anymore, and we'll go through that. I'll describe what it is. So there's a way that it can be done. Of note, the prostaglandin E2s, the Cervidil and the Prepadil and any other formulation, are sensitive to temperature, so they usually require cold storage to avoid degradation. That's one of the benefits of misoprostol. There's not required to have that in cold storage. It's stable at room temperature. And so especially in places where there isn't any refrigeration, it makes it easier to use. So the Foley balloon, how does it compare? Well, it's better than oxytocin alone. It's shorter induction to delivery interval. There's a greater use of oxytocin when it's used compared to when prostaglandins are used. It causes more pain than prostaglandins. And although there's no difference in delivery in 24 hours when compared overall, when you look at multipara in particular, it's not as good as prostaglandins. There isn't as much hyperstimulation with fetal heart rate changes. And when there seems to be a decreased risk of C-section when compared to oxytocin alone. And this is like another interesting thing. Why would there be less of a C-section? Well, it all depends on what your endpoint is. It's one of the chapters that you read when you look at cervical ripening is the definition of failed induction. People will do a C-section for a failed induction, and it could be, no labor or no delivery within 12 hours of starting oxytocin. That's one definition of a failed induction. So it all depends on your endpoint and your rationale for doing it. So if that's your definition of a failed induction and you're going to do a C-section if they're not in labor at the end of a certain time period, yes, a Foley balloon will probably decrease the risk of a C-section. So all that has to be, their definitions are important. I don't think anybody in the studies induces people for 4 or 5 days, which we sometimes do, and it works. So that ripening device, that double balloon, 100 cc in each balloon, it's probably as good as prostaglandin, better than oxytocin alone, with less hyperstimulation. But only in Dr. Attad's hands does it seem to work really, really well. Other people who have tried to duplicate his studies don't get the same results. Dilapam is one of the synthetic dilators. If used properly, and that asterisk means you have to get it to the internal os. Just sticking it somewhere but not through the internal os isn't as good. But when used properly, it's very similar to prostaglandins. If you don't look at whether contractions are caused, it does cause the same degree of cervical ripening. But there's probably a significant finding, especially in the meta-analyses, is there probably a slightly increased risk of infection. And it doesn't seem to be related merely to retained fragments of dilapam. It's there with laminaria as well, an increased risk of infection. All of these things are sterilized with laminaria because they are a natural product. Even if you stick them through an autoclave, you don't destroy spores. So there's always the risk of that kind of infection. And they've documented different, depending on where they're harvested from and that kind of stuff. There are certain bugs that happen are more likely to happen in certain compounds. So there's that risk of an infection is real, even though it's a relatively low risk because it took a very large study to demonstrate it. So when we look at prostaglandins, especially E2 versus oxytocin and amniotomy, certainly prostaglandin fares better. And as I said before, less analgesia, less oxytocin during the course of delivery, shorter time to delivery. the site of application for prostaglandin E2. The product called Prepadil is an agent that is a 0.5 milligram of prostaglandin in a gel that's inserted into the cervix, usually under speculum guidance. You could do it blindly, but it's usually injected into the cervix. When you have a highly unfavorable cervix with a Bishop score of 0 to 3, it works better than intravaginal at achieving both a cervical change and at getting someone into labor. But it's not as good as vaginal at inducing labor. So if it's not just I think dose-wise, more contractions occur with a vaginal application, but also more side effects. And when you use the higher doses, you run into the side effects of fever and those kinds of things. The Cervidil minimizes that because it's a sustained release.
And also the E2 gel is very irritating locally, so people who had multiple applications would really complain of a lot of vaginal symptoms.
Of
the vaginal gel.
The vaginal gel. E2 gel. Of note, you always have to take the manufacturer's instructions into consideration. For example, Prepadil gel is the 0.5 milligram that's inserted intracervically. It was studied that it was no better than a full milligram, so they went with the 0.5 milligram. The manufacturer says you can use a dose every 6 hours, so of course everybody gave it every 6 hours. But it doesn't matter a bit if you give 3 doses every 6 hours, or if you just give 1 dose and wait 18 hours. So it certainly sells more product, and you can't use oxytocin before 6 hours. But intracervical continues to work after 5 or 6 hours. It just keeps working. And that's true about Cervidil as well, and we'll talk about that. And there seems to be no difference when they looked at this in terms of maternal acceptability. And the other way intravaginal PGE2 is given is actually in suppositories. So that's, the gel, depending on the formulation, can be uncomfortable. When you look at cervical versus vaginal application, the change in the Bishop score within 6 hours was better with intracervical, but when you looked at the endpoint of length of labor, C-section rate, delivery within 12 or 24 hours, it's no better. And overall, when you don't look at highly unfavorable cervices, the endocervical isn't as good as vaginal applications in the Cochrane review because of the increased number of people who go into labor with the intravaginal approach, because most people don't have highly unfavorable cervices. Head-to-head trials of the 2 proprietary compounds, the Cervidil versus Prepadil, showed no differences. Similarly, Cervidil had certainly a shorter time between insertion to vaginal delivery, time to active labor, but in terms of who ended up getting delivered, it wasn't very different statistically. Misoprostol, depending on how it was given, when compared to prostaglandin E2, showed it was a better induction agent. Shorter time to achieve labor, shorter time to delivery, less need for oxytocin, but more hypertonus and tachysystole occurring later after the dose than with prostaglandins. The other thing in terms of route for prostaglandins, it's important to remember when you insert prostaglandins into the cervix, if they're just in the cervical canal, they probably won't cause many contractions, and so it's going to work directly on the cervix. If you jam the applicator up high and squirt it in and it dissects the membranes, there's lots of absorption in that extraovular space. And you get tachysystole and lots of labor and sometimes tetanic contractions. If a lot of it spills out of the cervix into the vagina, you're going to get more absorption of it and more contraction. So the placement of the product makes a huge difference. All right, so what are the other alternatives, just to flesh out things here? Thinking about antiprogestins, which we don't have a lot of use facility with. Withdrawing progesterone enhances myometrial responsiveness, induces cervical ripening. That doesn't seem to be mediated by prostaglandins. And if used alone without misoprostol, can be effective in inducing labor and in promoting terminations. And the effect is thought to be mediated by cytokines. RU486 is probably the most common one that we think of, has a very long half-life. We don't really have accessibility to them here. The misoprostol vaginal insert, they've tested the 50, 100, and 200 microgram products. And I think it's to be used over 24 hours, not only as a cervical ripening agent, but also as a induction agent. You can bet when this comes on the market that it won't work as well as your little tablet that you're using now, because they're going to market the thing that produces the least amount of tachysystole, that has the most even absorption, the minimum amount of side effects. Because this happened when we went from, the backroom gels of prostaglandin E2 to Cervidil. It didn't work as well as the original product, because it's proprietary and it's not going to be cheap anymore. It's not going to be your 25-cent pill that you can use, because they have to pay for all the research and development and make their profit. So by using this, it will be a good agent, and it will be another piece, something in our armamentarium, but it will be different than what we're used to using now. Hopefully it'll be helpful in getting people into labor, besides something other than oxytocin. Vaginal prostaglandin E2, it's more of an issue in other countries, because they have the tablets or gels elsewhere. And they probably compare favorably against Cervidil, because they can be dosed accordingly. You can change your dose for a multip versus a primip versus the response with contractions, that kind of stuff. You can use more or less gel, more or less vaginal suppositories. I didn't get to the thing about Cervidil. Cervidil is a vaginal insert that contains 10 milligrams of prostaglandin E2. Again, the manufacturer says, you can put another one in after 12 hours. It releases 0.3 milligrams per hour. There's enough in there for a day. You don't have to change it after 12 hours. And if someone's doing nothing after 12 hours, you don't have to take it out. But we do, because we're really good at reading the manufacturer's instructions. It is no different if you leave the damn thing in there for 24 hours. It doesn't change its effectiveness. So you don't have to believe the package insert. That's designed to sell more product. It has plenty of stuff in there to last. So yes, you should take it out if someone's in active labor. But short of that, if they're not doing anything, you can check them, but leave the stuff in. You don't have to put a new one in. The changes will happen regardless. Okay. Fibronectin levels maybe can delineate a population. We talked about that, who needs cervical ripening. Lots of other things studied, including acupuncture, nitric oxide donors. Hyaluronidase is actually a very nice cervical ripener that doesn't cause contractions. Outpatient, there's nothing that's been found to be safe, but there is higher satisfaction if some portion of it is done on an outpatient basis. Herbal preparations, not well studied in terms of ability to, but these are out there and people take them. I'm going to skip over this next thing, but this is, I did not have a chance to look everything up, but if you look at the right side of the right column, in 1997 dollars, it'll show you what everything cost relatively. Now, if you look at Prepidil and Cervidil, they're both, the cost, not what they charge the patient, they're both well over $200. So just a large amount of money for something that didn't cost that much. When you look at the prostaglandin E2 suppository that people compounded and divided into a bunch of 2 and 3 milligram doses, it certainly was much cheaper than what it cost at that point. But yeah, the things are really expensive, and I think misoprostol is still just as cheap. It's maybe $1.34 or something like that in today's prices, but you chop it up in 4 pieces and it's still pretty cheap. So, and of course it depends on the deal that the hospital has with the pharmacy. I think I got these numbers from the hospital I was at the time. But I didn't get all the cost comparisons. So they are hugely different in their costs. And I think that's the last slide. So I'm happy to take any questions. Yes, sir.
So just in terms of the whole legality and off-label use of especially the Satitek, one, has that been an issue? Meaning had people taken people to court because of the fact that they got consistently whatever and then had, and because it was an off-label use?
I'm sure they will raise that issue because it's, it doesn't play well. But at the same time, they can raise any issue.
The ACOG has committee opinions that came out, sort of the week after that letter came out from Cyril or whoever it was that sent out the letter, that it was quite direct about supporting their constituents for use of something that had studies in the literature to back its use and use safely. And I think the biggest thing is going to be it's for when it's used indiscriminately. When you have the nurse put it in and you don't watch the tracing, or you put it in and you send them home, and that kind of stuff is when you're probably more liable. And I'm sure they'll go for the deepest pocket, which is why the company sort of.
And also, I think the FDA actually has a separate statement that says that they don't regulate medical practice.
Right.
What they do is they regulate drugs and food, and they regulate labels and indications, and they allow what comes to market to be sold in the United States. But once something is available, if there's a body of medical literature that supports its use, they're not, they don't regulate medical practice. So physicians and physician organizations know the body of literature, and they can choose to use a drug off-label. I mean, most drugs aren't labeled for pregnant women, and we use them all the time. So I think the point is also that there's a body of literature that supports its use, physicians, and it's available for sale and purchase in the United States. Like some of these drugs aren't available in the United States. If you really want them, you probably have to smuggle them in. But absent that, if it's available, you can use it. And then you just have to be careful, particularly if there's a high risk to that drug, some serious side effect that you document on the chart while you're using it. But let's say, misoprostol, you've got a patient 20 weeks pregnant with an IUFD, viruses are in section. And so in the past, they're very careful about using reciprocity in those patients because there's an article that say it ruptures the uterus, but still you can use it, and you just have to document how you're using it, why you're using it, you've done it as breastfeeding, as opposed to just doing another C-section with that baby in 20 weeks, just right.
Yeah, I think the package insert for Cytotec now reads that it's not for use in pregnant women for the indication that it was approved for. So you can't use it to prevent gastric ulcers from NSAIDs in pregnant women.
The lawyers will look at that and they will raise those issues.
Yeah.
They will raise the issue that they should raise the issue. I mean, that's their job. Yeah, that's what they do.
So, I have a question.
Yeah.
So there are several different studies in using combinations of procedures. When you look through the history, has anybody tried to develop a laminaria with prostaglandin in it?
No, I have not seen that. People have looked at combinations of mechanical with prostaglandin, of Foley with prostaglandin. I think it's the only thing that's been studied. I think it has actually been actually showed a decrease in length. It has multiple effects, so a decrease in the interval to delivery. But on the other side, because of the prostaglandin, there's also the higher risk of the tachysystole that you usually avoid with use of the Foley catheter alone if you don't use oxytocin. So, I think that there's only a couple of studies that looked at that, and most people say, the cervix changes as you are moving towards labor, and so none of this really speaks to using various agents serially appropriately. So and people really haven't looked at that, and there probably isn't a good delineation of a population to decide, how you would compare it. I'm sure it would be tediously studied. So I'm not aware of any, prostaglandin-coated laminaria.
There was some older stuff. You mentioned all different types of agents over the years.
Uh-huh.
And one was estradiol
Uh-huh.
that they inject to women to help with prior to induction.
Uh-huh.
Do you have any more information? I know they used to use it before, but say modern era.
Well, I'm only aware of the vaginal application from it. I'm only aware of the vaginal application rather than the systemic use. So, and I think with systemic use, you'd have the issues with clotting and that kind of stuff. But vaginally, I know it doesn't cause contractions, and that when locally applied, and it does lead to cervical ripening. And I think a lot of those agents that do that have fallen by the wayside because everybody wants to have the baby already. And so the agents that are most popular are the ones that sort of blur the difference between cervical ripening and induction. All right. Thank you. Great. I don't know.
No, he's being locked out. Locked out. No. And he's in the OR.
Yeah.
He's like locked out.
I am.
Yeah.
Okay.
I just don't know how to make it stop. It's going to be quick open.
I'm ready.
For the next 2 hours. I don't know if he has to. I don't know if he has to. This is his tube, I think, right?
Yes, this is his computer.
That's all you.
It's still early enough for the
Little
little
emails what you do. And I finally got a copy of the last one.
I don't do this at all.
So, I think the first one's learning, if we don't show up where we're supposed to be with respect to patient care.
All right.
In answer to your email,
I told him
Yeah.
about our case.
happily, I will be picking you
Okay.
after the wedding,
Yes, no problem.
which is October 5th, so
Okay, good.
after the first week in October, we'll just set it up.
No, I know, and I knew, what's her name?